Okay, so today's webinar is an update in birth control for the postpartum period. Please help me welcome Leslie Fung.
Hi, everyone. My name is Leslie Fung. I'm a nurse midwife at Eisner Health. I'm happy to be here. So a little bit about myself. Before I became a midwife, my background was in public health, and I did birth control education and helped to evaluate a birth control education program with UCSF. And so some of the materials that you do see today is from my old work. And then after public health, I became a nurse and worked in primary care for a bit, and that was in New York. And so I just moved back to California, and I've been with Eisner for almost a year now. So I am excited. It feels full circle to be talking about birth control and in California. And so we can get started. And thank you, Jennifer, for having me today. So let me share my screen. Okay, can everyone see the screen? And so at any point, if you have questions, feel free to pop it in the chat, or if you raise your hand, Jennifer will be monitoring that for me. And so, yeah, let's get started. And so our agenda today, we're going to talk about the importance of postpartum birth control, why it's important to talk about it, how we talk about it. We're also going to, I'll go through all the emergency contraception options. And then after that, we'll go through the birth control options, specifically for being postpartum. And then I do want to spend some time to talk about how we should counsel about birth control in a non-judgmental way and really meeting patients where they're at in terms of their birth control journey. And so we will practice through case studies and a role play if we have time. And then I want to share some resources that I personally use as I practice, so that there's going to be a lot of information today. And so having resources while you talk with patients is helpful, even for me when I talk about birth control. And then we'll have questions at the end too. And so some of the objectives I already kind of talked about, but we're going to review the importance of birth control in the postpartum period. We're going to examine the options that are appropriate for postpartum, discuss elements of birth control counseling and how individual priorities can influence their choice of method. And then again, I'll talk about the resources that I have to share with you. And so discussing birth control and postpartum, why it's important. Well, first, it's important because they just had a baby, and we do want our pregnant or our postpartum patients to recover, especially to allow the body to rest for at least 18 months. And this is recommended by ACOG to allow the maternal body to recover with nutrients, especially if they're breastfeeding, and avoid pregnancy if we can within the 6 months. Because if there is a short pregnancy interval, there are risks associated with being in a short pregnancy interval, and that means just having a baby within this time period, and that would be with low birth weight, or preterm births. And for people who've had a C-section as well, it's important that we give the 18 months or allow the 18 months, because with the uterine scar, if they want a vaginal birth after a C-section, there's a risk of uterine rupture, which means the scar can open up if they do try for a VBAC. Additionally, there is this transition into parenthood, and it's important that they have the time to focus on their new baby. And we don't know. We can't assume that everybody has had a positive birth experience. And so sometimes, especially in our country, a lot of people go through birth trauma. And so it is important that we give them the space and allow people to recover and focus on their current baby. And so in the postpartum period, it is an ideal time to offer contraception. This could be because there's motivation to focus on the new baby. Also, there is access to healthcare services during this postpartum period, like the Welcome Baby program, where you all will be meeting with the patients after they deliver. And so they do have access to seeing more healthcare services right after their delivery. And also depending on where they deliver, they do have options to receive contraception even after discharge or before discharge. And lastly, it is important that we recognize the dark history that it was present in the US. This can be a whole lecture, but in the 1940s to the 1960s, there was forced sterilization programs that was fueled by the eugenics movement. And so a lot of that was deeming people who are unfit, especially in targeted marginalized communities, so people of color, people with low income. And so they were forced into sterilization and not been given a choice. And so when we talk about birth control, especially in the postpartum period, it is really important that we are offering choices, and that's our job, is to offer choice and present all the information that we have so that we can make informed, so they can make informed choices about their health and about their future pregnancy plans. Okay. And so we have an idea of like, how soon can you get pregnant again? This might be important in terms of how we guide our counseling. And so if you're not breastfeeding, average time is, so ovulating means when the egg is being released can be 2 to 3 months postpartum. And so the earliest is that they've seen in the research is 25 to 27 days, so about a month. And so patients are pregnant, or I'm sorry, our mothers can be ovulating before they get their period. And so that's something to bring up, that there could be so much going on with the new baby that they don't even know that they're ovulating already. And so it is important to bring that note up so that we can plan with the patient and give them an idea of why it's important to know their choices. And so the goal to start talking about birth control, in my practice, we talk about it at their 28-week prenatal visit. And we hope to have a plan for them in their prenatal care. But ideally, it would be at least 2 to 3 weeks postpartum. Okay. And then so when we check for pregnancy, and before we even talk about the options for birth control, we want to know if they're already pregnant, because if they are already pregnant, then these options are not going to be available to them. And so how we can check, so this is based off of the CDC guidelines. This is the individual criteria. So if no symptoms or signs of pregnancy and meets one of the following criteria, so if they have had their period less than 7 days, if they haven't had intercourse, so usually how I ask is like, have you had unprotected sex in the last 2 weeks? Has been correctly and consistently using a method of contraception. So like if they've already been discharged with a contraception method, then they're usually covered. If they've had a miscarriage or an induced abortion that was less than 7 days, if they're within 4 weeks postpartum. And so this is something that where within that range, and if they're exclusively breastfeeding. And so this is the lactational amenorrheic method, which I'll talk about later too. And so I wanted to start with emergency contraception because usually when I see my patients, they're at their 6-week visit, or I'm on the telephone with them at their 2-week visit. And so sometimes it's not uncommon that our patients already have had sex before I see them. And so it's important that I ask, and that we ask our patients, and to let them know that there are emergency contraception options out there. And so there are 3 types. So first is the copper IUD. And the copper IUD has to be placed. It's an intrauterine device. It does not have hormones. It's almost 100% effective, which means once it's placed, we can, that it's pretty effective in terms of preventing pregnancy. And so emergency contraception, I'm sorry to back up a little bit, also is if they've had unprotected sex, and they want, like we talk about Plan B, want something to prevent that pregnancy from happening. And so the copper IUD, they do have to be placed, it does have to be placed in the clinic. And so one thing to note is that there can be barrier access in terms of getting to the clinic on time. And so it's important to see where they're at in terms of where the closest clinic is for them, and if they have access to meeting with a healthcare provider right away. And I will go through how we can look at clinics that are in the area for depending on where they're at, and where we can call in a little bit too. The other 2 forms, Ella and Plan B, they work similarly, but Ella is a prescription birth control, and it works up to 5 days as well, but it's more effective the sooner you take it. And so with Ella and Plan B, they both help to delay ovulation. And so when you take it within the 5 days, it helps stop the egg from being released, so that if they've had unprotected sex, the sperm won't meet the egg. And so with Ella, we do need to get a prescription for it, and I'll show you on the next slide how we can do that. And then also the third one, Plan B, is the one you hear about. This is the one that we can get at any pharmacy. You can also get it through prescription, but it is important to take within 3 days, and it's more effective the sooner you take it as well. And so I know this might be hard to visualize, so this one I think is a better visualization of the differences between Plan B and Ella. And so they are different hormones, but they work very similarly, again, in terms of delaying ovulation. With Plan B, it's 3 days. With Ella, it's up to 5 days. How effective is it? So Plan B is 89%, Ella is 95%. And Plan B helps, can be more accessible, where they can just walk into any CVS and pick up a Plan B, whereas with Ella, you have to get a prescription. And so how to get Ella, you can go to any Planned Parenthood clinic. So those are free to low cost. But if you are paying out of pocket, it will be $50. And so there are online ways to get Ella. So these are the Planned Parenthood Direct is an app that you can download. And you can see how to make a televisit to get the prescription. And NERCS and Project Ruby are similar online websites that you can use to get a telehealth appointment. In terms of getting Plan B, usually all pharmacies will carry it. You can even get it online on Amazon, I think. But it is up to $50. It can be as low as $11, depending on if you get a generic brand. But for both of these, if you do have insurance or if you have Medicaid or FAMPACT, they are covered. And so it might be nice as well, like even if they haven't had unprotected sex, to offer like, oh, if you want to ask your provider to have Plan B or Ella in case of emergency, they can always get the prescription for it, and then they just keep it in their house. And then whenever they have unprotected sex, they don't have to worry about going to a clinic or going to the pharmacy to get the Plan B. And so if people are breastfeeding on Ella, it is important though to pump and throw away the milk 24 hours you take Ella. And that is only specific to Ella. For Plan B, it's not necessary. If you're on copper, you don't have to pump and dump. And the reason is Plan B is of the same hormone that will be used in the other methods as well. And we can talk about that later too. Are there any questions about the 3 types of emergency contraception? Not yet? Okay. And so after they take emergency contraception, or if they do, it is important to note that to talk about starting a birth control option with them if they want. And so if they have the copper IUD, so the nice thing about it is it's the only method that works as both emergency contraception and as continuing contraception. And so they will be protected against pregnancy and up to 12 years. Ella, you can't start hormonal contraception before 5 days. So you have to wait 5 days before you can go on any other hormonal method. So for example, if they want to start on Depo and they took Ella, you have to wait 5 days before they start Depo, which is the shot. If it's a non-hormonal method, so if they want the copper IUD or if they want condoms, they can start right away. And you should use protection or abstain for 7 days after you take Ella. For Plan B or any generic version, you can start birth control immediately. You can start any hormonal versus non-hormonal right away, but it is important to use a backup method also for 7 days. And then some anticipatory guidance to let your patient know is that if they don't have any withdrawal bleed, which means after they've taken a hormone, a withdrawal period means that there's no more hormone, they should expect bleeding after. If they don't have bleeding, I advise them to take a pregnancy test. And so for pregnancy tests, just to let you know and let your patients know, the earliest that it can show up positive is at least 2 weeks. Okay, any questions about emergency contraception? Okay, so our first case, so we have a 40-year-old. She's G3, P3. She's 8 weeks postpartum and had unprotected sex 2 days ago. She does not want to have any more children because she gave birth 2 months ago. She hasn't gotten her period and is using both breastfeeding and formula. And so with this case, what questions are you thinking about, or that you want to like ask her, or I know we haven't gone through the options for birth control yet, but what options would you offer her? You can also, oh, I do see a question. Why can't you take if you weigh more than 200 pounds? So that's a great question. And so it's not that you can't take it, it's that sometimes it is less effective for people who weigh over 200 pounds. And so that's something to keep note. Thank you for bringing that up. Yeah, so you can offer her a copper IUD. Yeah, so there's really no wrong answer. You can offer any of these methods, but copper IUD definitely, since she doesn't want to have any more children, is helpful to have a long-term method. And if she wanted to just use a pill version, she can use either Ella or Plan B. But if she uses Ella, it'll be important to give her instructions to pump and dump her breast milk. Okay.
Leslie, we have one
Yes.
more question that was sent to me. How
Yeah.
does copper IUD work?
How does it work? Great question. So I will go into that, but just to let you know, it is so the copper on the IUD itself, because it's placed in the uterus, releases an inflammatory response. So it makes the uterus like a hostile environment where the sperm can't survive in the uterus. And that's how it prevents pregnancy. And that kind of also is why they have more side effects of cramping and heavy bleeding too. And I'll go into the side effects later, but that's a good question. Okay, great. So now we can talk about all the contraception options. So like if they have met criteria that they're not pregnant and we want to start them on birth control. And so I will be focusing first on options that would be appropriate for right after pregnancy. And then I'll also be going in order of effectiveness. And so based on this chart, you can see how they've organized these options. The first row, or the orange row, is showing, they're called LARCs, these three: implant, hormonal IUD, and copper IUD. Can I increase the size of the chart? I don't know if I can right now, but I will be going through them individually. So this is just an overview. So LARC methods are long-acting reversible contraception. These are the implant, the hormonal IUD, and the copper IUD. Sterilization is the only permanent procedure and permanent form of birth control. And so the reason why these are more effective than versus the pill, the patch, the ring, or the shot is really because once they're placed inside the body, we don't have to think about it anymore. And so why the green is the options in the green column, why they're really well instead of really, really well, is because we have to remember to take the pill every day, remember to switch the patch. And so I'll go over that too. And so lastly, pretty well means they're not effective. They are effective if you use it perfectly, but there are areas of user error. And so that's why this last row is the least effective methods. Okay. So permanent sterilization. So the first one is bitubal ligation. And so this is for postpartum people who have uterus, and it means tying the tubes or tied or cutting the tubes to prevent sterilization. And so how it works is it is a surgical procedure. So people will get anesthesia to help prevent the pain, and it is an incision that the surgeons will use, or the OBGYN does, to cut the tubes. And there's 3 types, but the doctors will usually go into that a little more. It's usually a 1-day procedure, and they can go home that same day. It is about 99% effective. Some of the side effects would be the possible pain and discomfort after the surgery, and some of the rare adverse effects would be the tube reconnecting, or any surgery complications. And so with Medicaid, with Family Pack, with insurance, it's usually mostly covered. If they're paying it out of pocket, it can be from $500 to $5,000. And so also, all of the information that I've put on my slides here, I've used from resources that I'll show you later. So I'm taking it from other resources. And so in California, we do need a 30 consent form to be signed 30 days before the procedure. And so this is why we do start talking about birth control at the 28-week prenatal visit, so that they can have the consent form signed in case they want the BTL before they discharge from the hospital. And I do have a question. Does doctor decide which type, or the client? Yeah, usually that will be up to the doctor, or I don't do the counseling for tubal ligations. And so that would be a conversation that the doctor will have usually during their consultation visit. And so depending on where they get prenatal care, so at Eisner, we do have a tubal ligation class that we encourage our patients who are interested to go to. And then they can always change their mind. So like, even if they sign the consent form, if they don't want the BTL the day of, they can always say no. But if they want the BTL, it is important to have it so that it doesn't delay them getting the BTL if they want it after delivery. I am usually not doing the procedure, but I'm not sure what type of anesthesia they use. But I think in terms of, like, if they're doing it during a C-section, like right after, then they are awake usually, because they're not getting general anesthesia. And so if they are having a C-section, they just, once after the baby comes out, they will have, they can do the tubal at the same time. And so that also goes into why it's important, if they want a tubal ligation, to have the consent form signed, so that if they have a C-section, it's already filled out and ready to go for them. Yeah, that is something I have heard, but I haven't seen recently in my clinic or heard about. And so that definitely would be a conversation that patients can have with the OBGYN for sure. And usually, like, I will also do the general counseling on tubal ligation. And if they have more specific, like, surgery questions, I refrain from giving that advice, just because I'm not the one performing it either. And so I would at that point recommend them to consult with one of the OBGYNs to talk about their options. In the case that people do have a tubal ligation and they want a reversal, it's not impossible, but the success rate of reversing a tubal ligation is not very high. And so that's also a conversation to discuss with their OBGYN as well. And usually insurance isn't going to cover a reversal. Any other questions about tubal ligation or BTL? Great. So vasectomy, and so this is the male version. If they have the male organs, it's a similar idea. It's when the tubes of the scrotum are cut to prevent the sperm from traveling through the penis into and creating pregnancy. And so this means that the sperm stays in the testicles. And so it is similarly 99% effective. This is a permanent sterilization. Um, it is important to ask because sometimes the partners don't know about this option. And so it is important to bring up that if they are included in the birth control counseling, because a lot of times I hear like, oh, I'm the one that had the baby. It's like their turn now. And so what is the chance? Oh, I do. Sorry to go back. Ectopic pregnancy. I don't have the exact percentage. It is low, but I'll look that up for you and let you know. I don't have it on top of my head. And so with the vasectomy, the benefits are permanent, shared partner efforts. Side effects are similar to with the bitubal ligation. There's discomfort with post-op. Adverse effects would include infection risk, surgery complications. And it's very similar. It's in terms of cost, Medicaid and FAMPACT will cover it. With no insurance, it can be pricey. And then how it's done, it's also a procedure. It takes about 20 minutes. They can be discharged the same day. And they also need a consent form. For a vasectomy, they will need to go back in 3 months before it becomes effective to test and make sure that there's no sperm in the semen. And so it's important to talk about backup methods for that 3 months after their vasectomy. Is there any specific difference with how tubal ligation? Sometimes clients ask about this. In terms of the specific, so I'm going to just go back. So these are the 3 types. In terms of the specific difference, it will probably feel similar during the procedure because it is going to be a surgery. Sometimes they do it laparoscopically, so it isn't open unless it's after a C-section. And so that is something to bring up, that if they're not having their tubal ligation right after a C-section, it will be a procedure and they will have to go into an OR setting and providing that anticipatory guidance where like there are little risks of recovery. There are some risks with the recovery in terms of infection and surgery complications. And so after that, in terms of how effective it is, it's effective immediately, but there will be some recovery time that's needed. Is there age requirement? So that's a great question. You have to be, I believe, old enough to consent. I forget if it's 18 or 21, but just so that you can consent to the sterilization on your own. In terms of how old you are, no, I think everybody, if you're younger than 30 and you've had like 4 babies already and you want to have a permanent sterilization, I'm not going to say no. Yes, there are, and that's what I want to avoid too, because if be told they're too young, and it's completely their choice. And I think that's how we should be framing it in terms of the tubal ligation, and see where they're at. Sometimes they want this sterilization because they've already had a lot of babies already, and I think that's fine, but I don't think anyone should be told that they're too young. In terms of what I've looked in the research, before 30, there is a higher percentage of people who regret it. And post 30 years old, there's a less percentage of people who regret it. And so that is something to take into account. You can present it that way. Like, I'm not going to say you're too young, but I will present the data where there is going to be more percentage of people who regret in before 30 versus over 30. So I wouldn't blanket statement that over everybody. What if a client has not had this? Yeah, that I think if they want it, they can. I think that not everybody wants to have children in their life. And if they are sure, our role is to offer them that choice. It's important that they are allowed to make the decisions for themselves. And so if they want it, I'm not going to say no. But I'm not the one doing it either. And so it is important that if a doctor tells them no because they're too young, that's not true too. Like, you're allowed to have a tubal ligation when you want it. Okay, those are great questions. Any others before we move on? And we can always come back to it too. Okay, so now we're going to go into talking about the long-acting reversible contraception. So these are called LARCs for short. So we've talked about the Paragard or the copper IUD. The other name for it is Paragard. That's the brand name. And so you might be hearing it interchangeably. And this is also the non-hormonal IUD. So there is 3 names for it: non-hormonal IUD, copper IUD, and the Paragard IUD. So the mechanism of action. So again, the copper ion creates this inflammatory response, making it difficult for the sperm to survive in the uterus. It's effective up to 12 years, and it is reversible. So once it is removed, fertility will go back to normal. Some of the side effects are heavier periods and cramping, and some of the adverse effects. So some of the risks would be IUD expulsion, which means it falls out, infection risk, and perforation, which means during the insertion, the IUD might go into the uterine lining or the uterine walls. And so this is covered by most insurances. And this is done in the clinic. It's really important for copper IUD and for the hormonal IUDs to talk about what the procedure will look like, because it can be painful for a lot of people, and it's important to recognize that it can be painful, because also most of my patients have heard it from other people, or like they've had their own experiences with it, and depending on the clinic will depend if there are pain management options for them. And so why it's painful is so how I describe it is usually it starts out like a pap smear, but there will be certain points of pain or pressure, and it can be from just how we're placing the IUD, because it is a foreign body that we're placing in the body. And so a lot of the times the uterus is not wanting it because it is a foreign body. And so that leads to a lot of the cramping that can come from during the procedure and also after the procedure. And so if they're getting it placed, to let them know to take the day off, to have someone like be able to drive them home or have a mode of transportation, and then also have ibuprofen ready before they go into the procedure and after the procedure. And ibuprofen is the recommended choice of pain medication because it acts directly on the receptors of the uterus, so it helps to prevent cramping that way. And so that's the one thing to talk about, how it can be painful. The second thing is to ask about their period pattern, because the side effects include heavier cramping and heavier periods. We want to know what their periods were like before they were pregnant. If they were heavy, if they were had a lot of pain during their periods, this might not be the best option for them. And so a lot of the times my patients will be like, I want something without birth control or without hormones. And then I offer them the copper IUD. It is important at the same time that then I ask like how their periods are. Because once I tell them, oh, if your periods are heavy in the past, this might make it heavier. And I'm not saying like you shouldn't get it, but just to let you know, it's going to be heavier and it's going to be more painful because of how it works. Okay. And sometimes it may depend on the hospital, but they can get it placed right after delivery. But there is a higher chance of expulsion if they get it placed after delivery. And so that's something to know if they get it placed before they get discharged from the hospital. So for the IUDs with hormones, there are 4 different types. So Mirena, Kyleena, Liletta, and Skyla. Mirena lasts for 8 years. It contains the most hormones. Kyleena and Liletta last for 5 years. They're like the middle level of hormones. And Skyla lasts for 3 years. They're all placed very similarly to how the IUD is placed. So again, mentioning how it can be painful, offering them to talk to their provider about pain management during and after the procedure. The difference between the hormonal methods versus the copper IUD is the side effects. And so for people who are on a hormonal IUD, they might get irregular periods, which means they might not get their period every month. They might get spotting, or they might just not get their period at all. And this is because the hormone that is released is progestin. And so progestin works by it thins the lining of the uterus so that there is no lining for the period to be shed, and that the thin lining helps to prevent implantation for the baby to grow, or for the pregnancy to grow. And so it also increases cervical mucus, which helps block the sperm from getting into the uterus. And then it also can help block or delay ovulation, which means it can help delay the release of the egg. And so a lot of the times my patients will be like, is it bad if I don't get a period? And no, it's not bad. It's actually, there has been some research that shows that if people have had heavy periods, this is a method to use, because it helps to not let the uterine lining get too thick, which can also lead to endometrial cancer and ovarian cancer. And so this also is a method to help prevent those risks as well. So there are contraception benefits, and also if you've had heavy periods in the past, this can also be a benefit into having lighter periods. So the implant contains the same hormone as the hormonal IUDs. And so this is going to be placed in the arm, and it's usually going to be like right here. And this can be placed also in the hospital setting, like before discharge, or at the 6-week visit. It can be placed at any time. But you do have to go into the clinic to get it. It's similar effectiveness, up to 99%. So I write 3 to 5 years because the packaging of Nexplanon says 3 years, but the research has shown efficacy for preventing pregnancy up to 5 years. And so this is kind of a shared decision-making moment of it's completely up to the person if they want it for 3 or 5. I've had patients that are like, no, like I want it out by 3 years because that's what I was told at the beginning. And so that's totally fine. I'll remove it and give them a new one. But it does last up to 5 years. So sometimes if they do go back for their 3-year removal, I give them the option. You can keep it in for 2 more years if you want. And sometimes people will want that option too. And so I keep it to 3 to 5 and then just let the patient decide how long they want to keep it. Some of the side effects. So this one, compared to the hormonal IUD, one of the more common ones is spotting for 6 to 12 months. So this one is what I hear is it's more annoying a little bit for some patients in overall, that they will have to wear a panty liner because they're spotting more and irregularly. And so something I will be letting them know is like, if you're okay with the spotting, you just keep panty liners around so that if you do spot, you're ready for it. Can amenorrhea be a marker of blocked ovulation at all? So I just stopped and can block. It was my just word choice. I'm saying similar things. Can amenorrhea be a marker of blocked ovulation? Yes and no, because you can still see. So amenorrhea means like no bleeding, and so it's hard to know if you've ovulated and there's no lining to be shed. So it's a little bit different where like ovulation is the release of an egg. And so blocking and stopping ovulation or delaying ovulation means like the egg is never released, whereas amenorrhea means that there's no bleeding at all. Does that make sense? Sorry if that's a little confusing. But with the implant, some people might not have any bleeding or periods, and that's normal too. And so some of the adverse effects or risks is infection. We are placing something. So looking at, and it is placed by a needle. So that's something to note. And so with anything introduced into the body, there's always infection risk, and there is implant migration risk. So it's not that common, but we should be able to feel the implant at all times. And so if they're unable to feel the implant, that's when they should come back to us, so that the next step would be to get an x-ray to make sure that it's still in the body, or we can locate it, and depending where it is, that we can take it out and put a new one in. And so with the procedure, we do give lidocaine. So there is definite pain medication offered, where we inject about 1 millimeter of lidocaine, and the actual implant is very fast. It takes about like 30 seconds usually after we place the lidocaine in. And so the most uncomfortable part for patients is placing the lidocaine. Okay, any questions about the implant? Okay, so now we're moving into methods that are pretty effective. And so Depo, you have to come back into the clinic every 3 months. It is a shot. It is the same hormone. And so you will see similar side effects of like irregular periods. It's invisible, which means like you won't be able to see it. There's nothing placed inside. It is a big amount of hormone. And so this one does have the most side effects. And so that means people's appetite increases. And so when people say like, I'm gaining a lot of weight, that's really common to hear, but it's really because their appetite is increasing. On average, the fertility takes the longest to come back to normal, up to 9 months. And so if they are planning for a pregnancy in the next like 2 years, that's something to consider, just because it does take on average to go back to normal. But I have seen patients who miss their dose and then they have gotten pregnant. With long-term use, the bone density can decrease. And so it's important that they do weight-bearing exercises and are on calcium supplements just to make sure their bone density doesn't decrease. But once they stop depo, their bone density goes back to normal too. And sometimes you can also get this right after your discharge. So it's important to let them know that they might have this option before they leave the hospital. And there is a depot calendar so that there is a 2-week window of when you can get the dose. So it's not the same, you don't have to come that same day. Like, it doesn't have to be exactly 90 days. There's a 2-week window of when you can get depot. Okay, and I'm just checking on time. I know it's like 10, so I'm just going to keep going. So birth control pills. So I'm going to talk about, there's 2 types, and the one I am talking about is the one with progestin only. So this only contains one hormone. It is the same mechanism of action because it is the same hormone, but you have to take it at the same time every day. And so there are side effects of spotting, nausea, breast tenderness. There's not many adverse effects with it, but it is important that you take it within like 2 hours, because if you're off by 2 hours, your risk of pregnancy increases. And so that is the main difference between this type of pill versus the combined hormonal pill. And so there is vomiting and nausea that can be associated with it. And so if you do vomit it out, that's something to talk about in terms of using a backup method. Okay. And the non-hormonal methods, so there is withdrawal. And so you can see that the effectiveness is still pretty high if you use it perfectly every time. So it is pulling out. Condoms. So condoms, I'm not going to go over it because I think we all know how to use condoms, but there are female condoms and male condoms. And so that's something important to know. Fertility awareness methods can be an option for people who don't want hormones. And this could be a good method for people who know their cycles very well. And so usually if they're like, I don't want any hormones, I don't want any birth control, I do say like, oh, what are your periods like? If they are very regular, so if they're coming every 28 to 35 days, this could be a good method for them. And this is them tracking when their periods are coming and when they're ovulating. Ovulating is usually 2 weeks after they get their period. And during ovulation, that is the time where pregnancy risk is the highest. And so if the people want to track their methods and they don't want birth control, they can be using a fertility awareness method with another type, and it can be a good option for them. And the diaphragm, it's not very common anymore, but it is a device that you need to be fitted at the clinic for, and you have to use spermicide with, and spermicide is a method, it kills sperm. And I don't see the diaphragm as much anymore. And so these are the non-hormonal methods that are recommended by the CDC and on the websites that I'll show you about later. But there is one that's newer. It's called Phexxi. I didn't put it in the slides, but Phexxi is it's almost like applying lubricant, but the gel is not a spermicide. It helps change the pH of the vaginal flora. And by changing the pH, it creates a contraceptive action to protect against pregnancy. You do have to use it every time before you have sex. And so that is a method. If people are interested in another non-hormonal method, to talk to their provider about. Okay, and so now I'm going to talk about the methods to avoid right after pregnancy that you might are more commonly heard about. And these are combined hormonal contraceptives, which means that now these methods contain estrogen and progestin. And so the estrogen is what makes it risky for people who just had a baby because it increases their risk of blood clots. And so being in a state of postpartum, there's already a risk of blood clots as we're counseling about DVT and so we don't recommend adding estrogen on top of it because then it increases their risk even more. And so, but after 42 days, these can be an option. And so usually after 6 weeks, they can use the combined oral contraceptive or the pill. And so it's very similar with progestin only. You have to take it at the same time every day. With the patch, you can put it on any place in the body, but it has to be changed every week. And then the ring is a device that you place in the vagina for up to 3 weeks, and then you have 1 week off. And so if you're on any of these methods of combined hormonal contraception, you want to ask about aches, which are the adverse rare effects. So abdominal pain, chest pain, headaches that don't go away, eye changes, including blurry vision, floaters, or swelling in the legs. And so those could be signs of stroke or DVT. And so something to look out for. The other thing is we want to check their blood pressure before they start on it. And then I'll show you a chart of contraindications to these so that we know how to best counsel about these methods. Okay, and so this is based off the CDC eligibility criteria. And so this is part of the contraindications or when we're considering contraindications. So that includes for being postpartum, again, if it's less than 21 days, we want to be avoiding combined hormonal contraception. And if you have any sepsis or infection, we want to be avoiding IUDs. And then with breastfeeding, similarly, we want to be avoiding combined hormonal contraception. Okay. So the lactational amenorrhea method. So breastfeeding helps stops ovulation because it releases prolactin, which helps suppresses ovulation. But to have this work, you must meet all 3 criteria, which means you haven't had a period, so you have to be amenorrhea. You're breastfeeding with no break of 4 to 6 hours in between breastfeeding. Sorry, let me say that again. So you're like exclusively breastfeeding almost every 4 to 6 hours. And so 4 hours during the day, 6 hours during the night, and you have to be less than 6 months postpartum. And so after being 6 months postpartum, this method won't be effective anymore. And I've listed the contraindications here. So if you have HIV, if you have untreated tuberculosis, if you have herpes on the breast itself, those would be reasons to not do this method. Does pumping count? Pumping counts, yes, if you're using, but it has to be within this time frame. So you have to be pumping within this time frame. So, but if you're introducing formula, that interrupts the schedule. And so that's why the formula, if you're doing both methods, it won't meet criteria. Okay. Okay, I know I kind of sped through the last ones, but we can do a case study. So we have a 28-year-old, she's G1P0 and is pregnant. And she's being counseled for postpartum family planning. So she's probably maybe in her 28-week prenatal care. She is not planning on breastfeeding. What options are not available to her immediately postpartum? Yes. Yes. So anything without combined hormonal. So no combined oral contraceptions, no patches, and no rings. Perfect. Okay. So starting birth control. So like this chart is helpful for if it's been some time after they've been discharged to figure out if they need a backup method or not. And so, for example, if they want the implant and they've had their period already, if it is greater than 5 days after their period, then they do have to use backup method or abstain for 7 days. But if they've had their period, it's only been 3 days, then it's you don't need additional backup method. And so this is this chart and why it might be helpful in terms of counseling for backup method when they start a birth control method. So this is also exams needed to start. And this, I put this here because sometimes there might be barriers into getting birth control in terms of what needing like a blood pressure check before starting. And so that's something to consider if in terms of timing of starting a birth control method. So if they wanted to start on combined hormonal contraception, it would be important for them to have a visit and get their blood pressure check or have you check their blood pressure before they start on it. Because a lot of the times we can prescribe via telehealth, but we do encourage them to come back for a blood pressure check just so that we have a baseline. And then we have them come in 3 months after to check in on their blood pressure 3 months after they start a combined method. So with the IUDs and the diaphragms, that's also an important assessment to do before they get the IUD placed. Okay, and so it's about 10:07, so I do want to now switch into talking about how we can counsel on birth control. But does anyone have any questions about any of the methods before we go into like how we can counsel? Okay. And so when we're counseling or discussing birth control with our patients, again, we want to take into account that like we don't want to be coercive. We don't want to put our bias or judgment into what options they pick or think that we know what the best is for them, because at the end of the day, birth control can be a journey for a lot of people where either they've tried so many methods and none have worked for them, or they have only known one method, or they don't know any methods at all. And so usually how I would start is, do you want to have any more children in the future? This usually is kind of a good start, because if they don't want to have any more children, that can be a good indicator to introduce some of the permanent procedures and see if they're interested in that. And if they do, then we can talk about reversible methods. So some of these questions I ask So have you tried or used any birth control methods before? This will give us an idea of what their journey has looked like in the past. And then you can cater your counseling based on what their previous experience is like. And usually if they're like, I've tried this method and had a horrible experience, I'm like, okay, we don't have to try it again unless they want to. Like usually then I don't even talk about it unless they want to hear more about it. Because a lot of the times if they've had a bad experience, it's sometimes unhelpful to talk about it, that same birth control, if they already have their own individual experience on it, because I would be just saying generally what that birth control is about. And then we can ask what their priorities are for birth control. So do they want it to be private? Do they want a long method? Do they want to come back into the clinic every month? What does their travel looks like in terms of getting to the clinic? Do they have a busy schedule? Are they really good at keeping track of taking a pill on the time? It's definitely up to them. So what's most important to them? What I said this again, and I like to ask, so like I'll introduce it at the 28 week, but sometimes they're not ready to talk about the conversation, to have the conversation. And so sometimes I'll just say, okay, like, we can talk about it next time. Or we can talk about it now. It's up to you, because it can be kind of a lengthy conversation. Or I'll present them the resources, and then I'll have them go onto the websites on their own to play around on the website, and then we'll talk about it at the next time. And so talking about birth control, we can plan for it, but it's not like a set thing that they have to decide in that moment. And then this last question is important too. So if they don't want any birth control, or if the timing is off from starting one right away, I ask, like, how upset would you be if you got pregnant again? And so this means that, like, we're lucky we're in a state that has abortion services. And that means if they did get pregnant, how upset would they be to use abortion services or to have another baby? And so that is something to bring up, so that if they would feel upset, or they don't want another baby or an abortion, to then focus on coming up with a prevention plan. Okay. And so this is just a list of considerations that I've mentioned already: hormonal versus non-hormonal, side effects, effort, adjustment period. So like if they started on the implant, letting them know it takes their body about 6 to 12 months to adjust. Procedure and pain. If they want to see their period every month, that's something to consider too. And so we're running a little low on time, but this was something that what is a nice video. I don't know if we can play, but I'm not sure if it's playing right now. But it is a video on people's experiences, and they talk about birth control, and it can be a nice review of everything I covered today, but with real patients' experiences in it. It's about like 20 minutes. And so on your own time, you can watch this if you like, but it's from UCSF, and I really liked how they presented birth control. And this is something you can share with your patients too. Okay, sorry, my numbers are all wrong, but this is case number 3. So we have a 37-year-old. She's G4, P4. She's breastfeeding and 2 weeks postpartum. She's tried the Nexplanon, but didn't like that she could see and feel it in her arm. She is busy with now 4 children and wants a long-term method. How would you start the conversation about birth control, and what important questions do you want to ask? And you can just type it in the chat too. or we can just talk about it, which is fine too. So if yeah, that's a great question. Yeah, what have you tried before? So, right. Ask about menstrual history. Yeah, perfect. What has been successful for you? Right. And that's important. That's a great one because they might have been on one that they really liked. And then they're like, I want to go back on that method, which is perfect and an easy conversation to have. Okay, perfect. Great. So this was supposed to be a role play, but we're running short of time and I do want to like show you all the resources. Um, but this is a patient, she's 20 years old, G1P1. She was on combined hormonal contraception, but then she got pregnant. So now she's 1 week postpartum. She's not sure if she wants to be back on the pill again. She wants to know more options. And so what kind of questions do you want to start off with, or how would you start this conversation? And what would be important to bring up? Yes, does she want long term or short term? Yep, perfect. Yeah, see where she's at. In this case, I want to check in to see how she was taking the pill before and whether or not, yep, for sure, ask if she's breastfeeding because that can definitely influence the type of birth control that she can take. And if she does want to be on the pill, the combined version wouldn't be a good option for her. Some other things to note would be, yeah, like you said, long term versus short term. Does she want to have children anymore? Did she get her periods? Things like that. Okay, one more. So she's 27-year-old G3P2. She's tried many options and doesn't want the IUD. And she says she doesn't want any birth control. So how would you start this conversation? Yep, exactly. Do you want to have any more children in the future? How would you feel if you became pregnant again? Yep, those are all great. Yep. And so great. Yeah, if she's exclusively breastfeeding, see where she's at with that. I would also like to check in into because she's tried many options, I want to hear about her experiences too. And hearing about her experiences is I think is important if you have the time to just to check in to see what their journey has been like. Yeah, exactly. Like if she's interested in other options like family planning. I think one thing to note is when people hear birth control, they automatically think of hormonal methods. And we want to offer that there's so many other ways of birth control beyond hormonal methods. Yeah, that's perfect. Like, what does your partner think? You definitely include the partner in this. And it can be just the conversation. Again, like nothing is like set and final, but it is important to just talk about it. Okay, great. Beautiful. And so this looks like a crazy chart, but it is just listing common conditions on the left-hand side, and then letting you know whether or not it's appropriate method of birth control. And so I made the ones noted in the orange boxes. So like if they are breastfeeding, diabetes, headaches, and how you read it is if it is a 4 or a 3, it's not the risks outweigh the benefits of the birth control. And if it's green, that means there are usually no risks. And then if it's a 2, it means that the benefits outweigh the risk. And so this is all on the CDC website. And so like one thing to know with combined hormonal methods is if they have migraines with aura, which means that they're seeing floaters or a feeling that they're going to get a migraine come up, they're usually not a good candidate for a combined hormonal method as well. Other things, high blood pressure, this is a postpartum period, and then smoking we want to check in about because, again, smoking increases the risks for clotting, and so that is also contraindicated with combined hormonal methods. This chart is helpful in terms of their birth control journey. So like say they started on one method and we want to know how to switch to a different method. This chart is for the overlap. So starting a new method before stopping the old method. So for example, they were on Depo, or no, let's do an easier one. They were on the implant and they want to switch to the shot they want to switch to an IUD. Sorry, this was an easier one. So we would insert an IUD 7 days before the implant is removed. And so this is how you would kind of plan out switching the method, or it would be a backup method where you can remove the implant before you get the IUD placed. And so this prevents gaps and helps to lower the risk of pregnancy. And so this is where you can access this chart, reproductiveaccess.org. Okay, and so we have about a couple more minutes left, and I do want to go over some of these websites because this is how I use to also counsel, and it helps as a visual guide as well. These are all the links, and the first one is Family Pact. And let me see if I can pull up. Can you see the website?
You can, but you can only see a portion of it.
A portion of it? Okay.
Yeah.
What about now?
Yeah, better.
Okay. So Family Pact is like a program specifically in California that is focused on providing contraception, pregnancy planning for patients who may not have Medicaid, or without insurance. So this could be, they could be eligible for FamPact. And so I like this website because you can click on it and you can see like what's most effective, what's easy to hide. It's really easy to use. So this method, and it tells you if you click on it, all the facts about it. It's very helpful. So like I went through so much information today. You don't have to memorize it. You can just look at it with them and go on the website with them. And that's similar to this next one. So I use bedsider.org the most. It is something that, it is a site that I like the most. Let me go back to this. So Bedsider looks like this. I think it's more fun. And this one also has a Spanish version. So you can review the options in the language that they prefer. And this is a fun way to explore. The one thing about the Bedsider is that I like to use, so this is all the information, is you can compare them side to side. So if they want a Depo or if they want the progestin only pill, you can see side by side the effectiveness, the side effects, how to get, what their priorities are. So that's a nice way. And you can even go up to 3 if you wanted. So that one's a good option. Planned Parenthood, I really like their website as well. The one thing that Planned Parenthood has that the others don't is like if they are on, for example, the patch, and their patch falls off. Like, what do we do? They do, what do I have made a patch mistake. There's this nice quiz that like you can take if you've missed a pill, patch, or ring. And so you can click like, I've missed the patch. And then you don't have to answer those. But like, I didn't put a new one on, or my patch came off. This happened to me with one of my patients like 2 days ago. And then they ask how long, I don't know. And then this tells them and tells you how to either put a new one on or keep the same one on. It tells you if you need emergency contraception, and using a backup method. So that's really nice about Planned Parenthood website. The other thing I like about Planned Parenthood's website is that you can find specific services. And so you can see like morning after pill, like if they don't have access to their own provider right away, you can just put in, I'm just going to put in a random one. You can see all of the clinics in the area that might be affiliated with Planned Parenthood or not affiliated with Planned Parenthood. And then they will tell you about the services that are offered, the type of visits, the insurance, and payments at each of these clinic sites. So that's nice too, because sometimes Planned Parenthood itself doesn't take specific insurances, but you can see what insurance works with each patient and like how close they are. So then you can like easily pull up Google Maps and like see which clinic is the best for them. And so the last one is an app that you can download. It's the US Medical Eligibility app. This one is pretty much that really crazy chart with all the colors into an app. And so like you can click the method and then it will tell you if it's contraindicated in terms of what conditions they have. And so like if they clicked headache and they clicked with aura or without aura, they can see this is migraines without aura, and then you can see that there's no contraindications with any of the methods, which is nice. So it's nice to ask based on each person's pre-existing conditions. Do you know if there are available in Spanish? Yes, so Planned Parenthood, definitely. There is a Spanish option. Let me get back to that. So on Planned Parenthood, it's this button up here. And then, the last one is reproductive. Oops. This website also has a lot of like printouts that you can use, and they do have it in different languages as well. I'm sorry, I can't find it right now, but you don't need to, and you can see in all these different languages, like a birth control fact sheet. And so you can print this out or use it if they're Chinese simplified. It's all in Chinese. And so you can give that to them for them to review. And so you can familiarize yourself with which website you like the best, and then pull it up while you're offering birth control counseling. So they have visuals of it. And if you, even I'll forget some specific details. And so when I'm reviewing it with them, it's nice that I'm checking myself too as I'm talking about each birth control option. And that is it.